made us one of his first stops. He manages international medical corps Ebola response in Liberia, Sierra Leone, Guinea, and Mali. He has a team of over 1,000 doctors, nurses, infection control specialists, psychologists, nutritionists, program managers, and lots of support staff. He was the first person deployed to West Africa for International Medical Corps Ebola response in August 2014, and has since seen the startup of multiple Ebola treatment units that have served over 1,000 patients. He has a really long and super impressive bio. I'm not going to read the whole thing, but just trust me, he's super impressive, and you should talk to him afterwards if he can stick around. We also have Lawrence, who's the country representative for Liberia for Accountability Lab. He leads all their accountability work from Monrovia, including the Liberia Accountapreneurship Fund, the Accountability Change Agency, and the Accountability Initiative. He's also done lots of super impressive things in Liberia, including serving as the electoral commissioner for the Liberian Student Association in Ghana, the national coordinator for the World Youth Spirit Council project director for the Rotaract Club of Wisconsin, and lots of other super great things that he can tell you about too. So first we're going to start off with Sean, who can just maybe talk for about 5 minutes, a little bit about the situation that he's dealing with, what life's like there, the issues that they're facing. And then after Lawrence talks, he has a little demonstration he can show us as well. So
Sure. Thank you. And thanks for really, thanks for maybe I can start off with a bit of a scene setter. As you said, I arrived in Liberia well, actually, I went to Sierra Leone first in August, and then I moved to Liberia because we saw the caseload dramatically rising there. We actually started our responses in both countries at the same time, and really ramped things up in Liberia in August. As when I arrived, there were literally bodies in the streets. There were ambulances driving back and forth across Monrovia looking for beds in Ebola treatment units that didn't exist. There were bodies that were left for days in people's homes, and there was a real sense of panic in the country. We were the first NGO after Doctors Without Borders to open up an Ebola treatment unit, and that was the one in Bong County. We started that one on September 15th, sorry, and we opened a second ETU Ebola treatment unit in November in Kakata, which is between Bong and Monrovia, also in the countryside. We now see very few cases in Liberia. We went about 30 days without seeing any cases, and a new one popped up last week on Thursday or Friday. But overall, we've gone from having a full ETU. At one point in November, we looked at turning our morgue into a ward because we had so many patients, we didn't have space. And now we have empty facilities. We have occasional suspect cases come through, but there's basically no new cases, hopefully coming up in Liberia now, and hopefully we'll get to the 42-day mark when Liberia will be declared Ebola free. Sierra Leone still has a pretty significant caseload, but it's coming down. The numbers are coming down. We had a very big spike a couple of weeks ago. We had over 60 patients in one of our Ebola treatment centers there, and now the numbers have come down. The government is launching a new campaign to try to kick Ebola out of the country. I think the president's statement said, and there's going to be some more quarantines. There's going to be some more lockdowns. Those have had kind of mixed reviews in terms of their effectiveness and the secondary impacts. But it looks like Sierra Leone is heading in the right direction. Unfortunately, Guinea is not, I would say. And I think what we're seeing now is an increase in cases, and an increase in cases specifically in Conakry, which is a big and densely populated city. In Liberia and Sierra Leone, a lot of people talk about the health system collapsing and hospitals and clinics closed. That actually had kind of a positive effect, that it stopped health staff from getting infected. And in Guinea last week, we saw in the biggest hospital in the country, 3 doctors get infected. People still shake hands, people still kiss, people don't wash their hands. You don't see the same hand washing stations all over the place like you do in Liberia and Sierra Leone. So we're actually really concerned that things could get much worse in Guinea right now if we don't managed to stop the spread, and there's a lot of community resistance there. A lot of health workers have been attacked, actually. Some have been killed. So I guess, we're all focused on getting to zero, and there's a lot of celebration right now in Liberia, and there's a sense in Sierra Leone that we're coming out of this. But I think we need to exercise some caution and kind of keep up the momentum, especially in Guinea. We've seen what happens when Ebola hits a city and hits it hard, and we really don't want to see that happen in Conakry.
Thank you. Lawrence?
Thank you so much for having me. And I mean, we back home we were trying to celebrate more. Uh, After 30 days, we're trying to reach 42 days. On Friday, Cowell got hit by one lady, which is a sad story, but we hope that we can like do all necessary contact tracing. Um, like you saw the video, the accountability lab has been much more doing what um, our office never closed in Liberia at all because we thought it was a responsibility. Ebola, like any other issue in communities like corruption, is also an issue of personal responsibility. So we've been preaching that throughout the crisis. That we also talk to musicians to take this project that you just saw as as something that they could use as a personal responsibility, not just stopping to creating music, but as people that the community look at you so much and have much respect for you as an icon. You should also go cross beyond making the music and get to the community and make a lot of impact. In July, late July, early August, when Ebola really struck Liberia, it was a hard thing. I mean, you couldn't drive and put people in your car anymore. People walk down the street. Literally, there were bodies in the street. One of these days, we were driving home, my colleague Francis and I, and then people pack. Every time you see people cluster, you know that there is someone who is being infected, but nobody's going to look at you. And the terrible thing is that during that period in July and August, the rainy season is at its peak. There are other diseases that strike the country as well, like cholera, there are a lot of diarrhea. So you don't know what is what. So once a person cries, everybody just stays away and just watched. And then people just literally started dying, body laying in the street. You got to be calling and a response. From the beginning, the government was really overwhelmed because we're shocked. Little did we know that we had two ambulances to over 4.3 million people. We never knew until Ebola struck. So taxis were being used as ambulances, buses, just any vehicle at all were used as ambulances. With time, the citizens started to form groups. A lot of individuals started taking it as a personal responsibility to get to communities, get to your neighborhood, make sure that when your neighbor is not sick, you know that you're not going to get sick because you cannot stop the kids from playing because they really never understood it at the start. So you have to be keeping that community relationship. So by October, the community has held a lot, and then help started to come from outside, which was also highly appreciated. The government started standing up, and then community started laying along with government. Media was helping. There were a lot of community togetherness. I mean, the strong thing is you cannot have a culture for over 500 years of shaking hands and hugging people, and it's just gonna go away just because something just struck. So amazingly, we managed to fight it. But Liberia cannot be much free. Sierra Leone and Guinea are still under attack. And once, because the thing is, you can say closed border is good, but we have borders that can never be closed because we share common culture and stuff. So you cannot close our border, really. We're gonna swim across. We're gonna do a lot of stuff. I mean, that's culture that I've been for ages. So we are really hoping that with other partnership and community relationship with chiefs and elders and forming more uh, communities that hold together. We hope that the people across the border can try to do their own community watch for how people cross and are they safe and things like that. More to recommend for going forward is a much more a family. You know, every time we say the world is a global village, I hope we look beyond just being just a village to being a global family. Because the more you become a family, the more you see what the next person next door needs, and you can provide it even if they're trying to provide it at a certain level. So when Ebola really struck Liberia, I mean, the news says it, right? But when you're on ground, it's totally different. I mean, you see broken hearts, you see a lot of things that were broken. Some of us couldn't. Some days you see people lying, you're literally crying, and you're driving, but you cannot help. I mean, when nurses are dying, who's going to stand up? I mean, they are the real soldiers that should be doing that. But I mean, it's good that I'm here on a fellowship. I mean, it's also like, okay, my heart is one portion is back home because obviously that's how you. Once you help put smiles on people's faces by the kind of work you do, because we work across different sectors, we work with young people to create things. So one of our uh, intervention is to do some. We did something called a mobile cinema. What we did is create an Ebola film and also anti-stigma film. So we took them from junctions to junction in areas. Once we show the film, then we raise discussion about it. So people talk about it and then try to take it as a personal responsibility to not hurt people because you need to live. You need to also be a contributing factor to the country and to your own family. So we started showing that around, and most of our projects are also what we call low cost project. We don't put a lot of money in the project, but we have a lot of hard impact. And we believe that what we're doing like can go a long way in helping people in Guinea so to also let this nightmare go away. So what a great job you guys are doing. I mean, the ETUs are doing marvelous across the country, but we hope that those ETUs are closed permanently, in a good note though, are closed permanently, that no one is going there. And maybe we transform them into um, some medical facilities to help those communities so that they don't come from one country to Morovia because the Phoebe gets overwhelmed. Phoebe, by the way, is the biggest medical center in Bon County. So if it's overwhelmed, definitely you come to cases.
Yeah.
People can die in a car. So yeah, thank you for having us.
Yeah, thank you for being here. I know I have a million questions I want to get your insight for. I'm sure lots of other people too. But one thing I want to start off is both of you mentioned sort of the plight of nurses and other health workers. And since I know we have a prop here, I'd love to hear a little bit from both of you. What is it like for a health worker in Liberia and Sierra Leone, in Guinea? What is their day-to-day life like, and how do they protect themselves? Maybe Sean, I know you have
Sure.
Some props.
Any volunteers?
Volunteers.
Anybody want to try this on?
Ali,
You want to try it on?
come on down.
So in Liberia, I'll pull this out and talk at the same time. In Liberia and Sierra Leone, most of the health facilities closed, right? So most health workers were protected by not going to work, essentially. In Guinea and now in Liberia and Sierra Leone's health facilities are opening. Safety is kind of a central issue, and actually, Ebola treatment units exist to do essentially three things. Number one is to keep health workers safe who are dealing with Ebola patients. Number two is to isolate patients, so it's a public health intervention more than being actually a clinical intervention. And the third thing is to provide some care. We still don't really know a lot about what care is effective. We provide IV rehydration, we treat malaria, we treat bacterial infections. But really, at the end of the day, it's about keeping people safe, right? So in Ebola treatment units, we use the highest level of personal protective equipment, PPE. You may have heard of it. Anything that a doctor or nurse uses to protect themselves is PPE. So a glove is part of PPE, a mask. So PPE is not like a thing that's a kit. It's really any kind of equipment that you use to protect yourself. And so in the EPUs, we use suits, coveralls. There's a few different kinds. These are made by DuPont. It's called Tychem, and it's really heavy and hot. And during the daytime, Liberia, it gets pretty hot and pretty humid. And if you're wearing this, you're losing about 1.5 liters of sweat an hour. So
Hard to stay hydrated.
So normally you would have a pair of boots and scrubs on underneath. And then you step in. These come in different sizes. So this is an XL. You wouldn't normally need this size. You do want some space though. Yeah. So.
Okay, thank you.
So there's all kinds of different kinds of suits, but this has a sealed zipper. Oh, sorry. So you see the camera. This has a covered zipper. It has a hood that's built in, but we normally roll this up and then put a separate hood on. It has a mask built in, and you wear 2 masks. So we cut a hole in that first mask, and the doctor or nurse will wear another mask, and then goggles. We've got some goggles. We use ski goggles, basically. And so, how warm is it?
It's like I'm heating up.
Yeah.
Yeah.
So I didn't bring the hood, unfortunately, but add the goggles if you want. And then you wear 3 pairs of gloves. Right. So every movement, because of the heat, and these will fog up in about 2 minutes. So you can't really see. We put anti-fog on, or sometimes use toothpaste, which actually helps to defog. So every movement that you do in an Ebola treatment unit, you have to think through very carefully, because the more you walk back and forth, the hotter you get. You also have to wash your hands after every single thing that you do with chlorinated water. And so, yeah, this is like the equipment that we use to stay safe. But actually, the most important part is not the equipment itself, but how you take it off. So most people that are infected in a health facility or in an ECU are exposed in the doffing process. So it's a 20-step process to take this off. You take off your hood, you wash your hands. You take off your goggles, you wash your hands. You take off your mask, you wash your hands. You open this flap, and you'll be sprayed. You wash your hands again. Yeah, so it's, and we always have a safety monitor and a sprayer. So I had a lot of journalists coming early on asking me what kind of PPE they need to bring. And I said, unless you're bringing a sprayer with you, the machine and the person that knows how to spray, and you know all the 20 steps, don't bother, because you shouldn't be using it. It's really about how you take it off. And then every single one of these is burned after use. The only pieces that we reuse are the boots, the goggles, and the rubber apron. Everything else is incinerated. So we go through a lot of these.
What did you already say this? What is this?
This is called Tychem. So it's these are made for like people working in nuclear plants or in chemical production facilities, basically. And we use them for the Ebola response, but it's not intended really for healthcare. It was adapted for that use.
Do you want to keep that on?
Keep wearing it. See how you feel.
You can let us know at the end, like in half an hour, how hot you are. We'll take a temperature.
But this is really for Ebola treatment units. Now we're trying to, as health facilities, it's really comfy. As health facilities reopen, we're really trying to get people to use gloves, to use masks, to dispose of them properly. And in West Africa, where these kind of resources were not always available, it's very difficult, one, to get people to throw away gloves after each use because it feels really wasteful.
Mm-hmm.
But also, it's really difficult to get people to use them all the time because, for 20 years, 30 years, nurses have not used gloves and have not worn masks, and it's just not a common practice. So it's really like I liken it to if you're used to eating with a knife and fork, you all of a sudden have to use chopsticks, and you've never really been trained to do that. And sometimes there are no chopsticks. The supply chain is an issue for some of these materials. So, yeah.
What's the cost of a total like?
The total, so there, you can't buy it in a kit really. So we have to buy all these supplies individually. The suit that you're wearing there, I think, is around $20. And we use a different one now called Tyvek, which is lighter. It's a lot cooler, and those are around $7 or $8.
Yeah.
After one use, we incinerate them. Actually, almost everything, nothing that goes into an Ebola treatment unit comes out, except a patient. So really everything is burned. The sheets, any materials that go in, people's clothes. So when they go in, if they survive and are discharged, we have that shower. You saw that patient that came out. You have to leave all your clothes behind. You go in the shower, you bathe with chlorinated water, and you get a new set of clothes to come out. Nothing that goes in comes out.
When did you guys deliver to the lighter weights?
In October, mostly because of supply chain. These are really hard to come by. The global supply was eaten up basically by MSF bought a lot, and then other countries were stockpiling, so it was really difficult to get them. But a critical element of this is that you have to have every single piece for it to work, right? You can't be missing something, and so the logistics is a huge part of this, and making sure that you have all of the supplies in place. All the goggles, almost all of this has to be sourced internationally. You need different kinds of goggles because people have different kinds of faces, and you need to be able to have a seal. So we have 5 or 6 different kinds, and people figure out which works best for them.
Great.
Yeah.
So one of the things that I think we've all heard a lot is that, a big reason for the explosion of Ebola in the countries where it did was a weakened health system to begin with. And there is, I think, a lot of hope, as you mentioned, Lawrence, that the ETUs will turn into more long-term health and strengthened health systems. So what do you think needs to happen for that to occur? And what is sort of your hope for that? That
Yeah.
path.
I mean, one thing that we hope for is really having nurses protected. I mean, if those who provide in the healthcare cannot be protected, then it's. But I think if the education gets stronger, if you're educating people get stronger, because if you don't have stronger nursing institution to produce these people that will be able to take care of these facilities, the facilities will be there to maintain them. So you need good nursing education. The ones that are there just need to be strengthened so that we start looking at even diseases that are not that haven't occurred yet. Because I think the issue too was the nurses were not a little bit ignorant and overlooked the disease because it shows symptoms like any other waterborne diseases and like cholera or stuff. So they just thought it was just the same thing. So let's just treat it the same way. So I think if you educate people more, then they can take care of those facilities. And the facilities can let it go. But the thing too is the facilities are not made like permanent structures. So we have to look at if people want to go in to build ETUs, I think they should start supporting more of the facilities that are there already. And look at the distances between a crowded area and a hospital. Because if you're in Lofa, for example, you only have clinics in Lofa. You don't have a hospital in Lofa. So if there's a major issue, you have to come from Lofa down to Bon County. And then when you reach Bon County, maybe whatever disease you're suffering from is not treatable there. You have to go to Monrovia or you have to go up to Tabata. So it makes it difficult. So if you want to do these things, you have to do it. But then back to the question you asked previously about this, if you don't have these that you can buy, I think there was a student nurse, Fatu, in Kakata, who used just mere plastic as PPE, right? So she had four persons that were sick: her father, her mother, and brother and cousin. Unfortunately, the cousin died, but what she did was she just used a simple plastic, and in Liberia we call it 2 for 5, $2 for $5, right? So normally we just say 2 for 5, and then she used that, and then she had to save four persons, three out of the four, which was a good thing. I mean, it's just to encourage people so that when you don't have money to buy these ones, you can be able to take care of yourself. This is possible.
Great, thanks. And then I'm gonna let Sean talk about his thoughts on this health system strengthening, and then I'm opening it up. So think of your questions.
Yeah, I mean, I think so. The Ebola treatment units are really about this kind of emergency phase, and the focus now is on getting the health facilities to reopen, but safely. So, I mean, we all want to see a lot of people dying of malaria and other very simple to treat illnesses because the health facilities closed. But what we don't want to do is reopen facilities that are not ready, um, and that expose staff potentially to cases, because that'll, if nurses start getting infected again, it'll just collapse. So a lot of the focus now is on the supply chain, is on training, and really building in kind of support and supervision and mentoring on what we call IPC, infection prevention and control. So that includes um, chlorinating water, cleaning surfaces, cleaning tools, hand washing, um, and particularly case definition. So making sure that nurses and the very few doctors that there are in Liberia know how to recognize an Ebola case, which, as Lauren said, looks a lot like malaria. I mean, if you go to a hospital in most of Africa and you say fever, vomiting, diarrhea, body aches, that's probably a third of your patient load or something like that. So it's very hard to differentiate Ebola, and so we're focusing now on setting up screening and referral units outside of health facilities that basically are safe areas outside that every single patient, staff member, visitor, caregiver goes through. They're screened for a fever. They're asked a few questions to see if they have symptoms, and if they do, then if they meet the case definition, then we immediately isolate them at the facility and then transport them to an Ebola treatment center.
Thank you. Now I'm opening it up. So what questions do you guys have? Not even Mark? Okay, John.
Yeah, I mean, as a listener to this, you know, just looking at the case load graph for Liberia, it looks like in September, where it peaked, it has been down pretty dramatically, and so, and which is coincides with the time you were getting active there, which I'm sure did a ton. I'm just interested in how the sort of cultural, behavioral awareness interplay and the medical interventions kind of work together, and like how much of the tide turning do you attribute to one?
You go first.
Okay. I think it's difficult to really say where we can divide them. When people face the issue of life, what they tend to do is tend to look out for what kind of rope can I lean on to survive. And that survival rope was, okay, here we are. Our culture says this. If I met someone in Liberia for the first time, or a friend, an old friend, we hug, sometimes we shake and then snap, right? You wouldn't do it anymore. So when you see someone, I mean, sometimes you just hold your body or you just do your hands like this, and then you just stand. Culturally, that went against all you gave
The elbow one. This is the new handshake in Liberia. Yeah.
But where the medical came in is just to talk more to people and tell them, look, for this time, let's suspend whatever we have and then see that we are alive. And then when we stay alive, then we can find a new way of forming a new culture. So to get to the community, trust me, at a certain point, it was really difficult. People were not shaking, but they were like, we call it bossing, right? And they were hitting, but still here you still transmit. That is it. So we started telling people, you just have to stop it completely. But it took time. That's why from late July to September, it started claiming that fast. But then when people started seeing body literally on the street, then you have to listen to what the medical practitioners are saying, and then suppress your culture for the time being. Together, by ending of September, getting to October, the case started dropping because now you must listen to survive. If you don't listen, I mean, the next thing is that you could be infected or somebody else could be infected. So people were not kissing. You don't need to eat certain meats that are from the bush like that and monkeys. I mean, those are normal diets. Like monkeys, for example, is a normal diet. And you tell a Liberian not to eat monkey, it's almost like you're telling him not to eat fish, right? So, I mean, those are cultural things. So you have to talk to people, and then people have to take it. Once they see body on the street, I mean, we have to be medically conscious at the moment, just because we want to also survive. And that is where the stronger spirit of the community and education had to come in.
I guess I'd just add that it's not really the medical intervention that breaks the chain of transmission, right? So the things that stop transmission that lead to that downward slope in the epigraph are burial teams. So safe burial, basically, avoiding funerals, not touching bodies at funerals, not having physical contact, which, in August, everybody stopped shaking hands because they saw the bodies in the streets, and it became very real. When we saw it get to Monrovia, it got very real, and it kind of changed the psyche. And I think that helped a lot. It also helped a lot for acceptance of ETUs being set up and things like that. We haven't seen that psyche shift in Guinea, and I think that contributes a lot to the resistance there, because people still don't believe it. They don't believe it's real. They don't believe it's going to affect them. But yeah, so it's isolation of patients, finding them, quickly isolating them, getting them to ETUs safely, burial teams, and just kind of basic behavior change about not taking care. It's hard. Don't have a funeral for your dead. Don't take care of your sick child. These are really intense shifts for people, but it became very real, and people in Liberia in particular were, I think, quite open and quite willing to change behaviors and change practices, which we've not seen in Guinea, unfortunately.
So, talking about changing social norms, that's something that's very difficult. And I think it's especially difficult for sort of external people to come in and try to do that. So I was wondering if you guys could talk a little bit about the role of local CBOs and NGOs in making that change, and just sort of in general in dealing with the Ebola crisis in these countries.
So unfortunately, I would say a lot of local organizations have been kind of marginalized in the response. And it's because it requires, it's very expensive, and it's very complex in terms of the interventions. International Medical Corps had never responded to an Ebola outbreak. We had to figure it out. We got trained by MSF, but we had to learn, and so did all the other agencies involved. And I think that there was an issue around absorption capacity to be able to deal with the supply chain, to deal with all the money that you need. So a lot of local NGOs were kind of set aside initially, and international organizations came in and took on opening Ebola treatment units. I think we realized soon thereafter that we needed these community organizations to be much more involved. And so I think it changed, especially around behavior change messaging, especially around building acceptance for burial teams to come into your community and take away your dead and not have a normal funeral. And I think we're not effectively using it in Guinea now. I think that lesson was learned in Liberia and Sierra Leone, that it's a really critical part. And local NGOs are not going to set up Ebola treatment units. They're not going to run burial teams probably, but they can build acceptance for those interventions and create a safe environment for other agencies and for the government to come in and do these interventions that are quite controversial for a lot of communities.
Yeah, I mean, just to add up, if you just observe what the focus of most of these CBOs is basically to allow community to understand and contribute from their own perspective of the way they see intervention. And they allow, when they educate people in the communities, those people can also volunteer as burial members of a burial team, and they can also volunteer to go and give in, because at a certain point in Liberia, it was like an SOS call, right? People were literally walking to call centers and volunteering their time to just be there and receive because they have the skills. And those things were a contribution from the CBOs. And some people, some of these groups were not formally uh, registered as a legal entity, but it was just collection of people who said, no, we have to stand up and don't let this thing kill us and take us from our life and our area. So most of the time is, I think at a certain point, obviously I agree that we cannot allow, and we don't have the capacity to build ETUs. But what we have the capacity to do is to conscientize the community to give manpower that can help doctors and nurses in the ETU to do like little things, which together can form the bigger ball of getting rid of the disease completely. And I think those are some of the roles that you can have those CBOs play, because the thing is, they know their community better. They know the way the community thinks about a particular issue. They know the way the community can, that thought can also be refined within that same context, because some of those people are the people that really drive um, the thoughts so fast. So if you have, for example, the chief getting involved and influential young men and women getting involved who really push the culture, and then if they tell you, oh, let's change it, people are ready and willing to change and help contribute.
It's also really important for we talked about the prevention aspects, but also for reintegration of survivors or people who are discharged, because you take in patients as suspect. Some are discharged after they're cured, and some didn't have Ebola. They come to the treatment center, we screen them, we test them, they don't have Ebola. Those people have the hardest time going back into communities, because the communities are actually really smart and know that that person might still have Ebola. Because they've been in contact with another patient, or because they were at the Ebola treatment unit. And so a lot of those people had really difficult times reintegrating with their communities, and that's another area where local organizations can provide a lot of support to do that negotiation process with local communities, and to provide some of the care, whether it's medical follow-up or psychosocial support or material support. Actually, when people are discharged, they get some food rations and things like that. So local organizations are really useful in kind of bridging that gap with community.
Yeah, and I think you touch on a subject that we've heard a lot about, which is the stigma of people going back.
Yeah.
And if you could both sort of talk about that a little bit. So what does life after Ebola look like? Is there, at first we read a lot about, the stigma and that survivors were facing. Is that changing at all as time goes by? And how many of them are sort of then helping with the sort of prevention effort after prevention and treatment?
Well, they're superheroes. So the survivors, they're like Superman. They're immune to the virus. So we've actually ended up hiring a number of survivors. Some of them were our patients who happen to be health workers, who we hired. We had one physician's assistant, one nurse, and they can go into the ETU without wearing that. So it's great. They can stay in. They can stay in for hours or overnight, or they're critical, I should say, for taking care of children in the ETU, unaccompanied children. There's no way that you could stay. We just can't stay inside in PPE to take care of kids all day and all night. So the survivors have been an incredible resource for us. But also in terms of building that acceptance, we have a few survivors who are prominent community members who are able to go back and say, look, like, I'm not a risk. We need to stay vigilant. They're effective on prevention. They're effective on successful reintegration of people and affected families, because there's also a lot of stigma around families that have had members going into the ETU, family members who have been sick or who died, and so the survivors, they're our best ambassadors, really. I don't think that there's a lot of stigma now. There was in the beginning, but I think that there's, especially in Liberia and to a certain extent in Sierra Leone, I think people realize that they're not a risk to the community and that they're actually really valuable in their response.
I think just a little bit to add to that is, I mean, at first you understand that if a female comes out and a male comes out as survivor, the male is still at risk at a certain level. It still poses a risk, or rather, a certain level, because I mean the virus is still in your sperm cell for 90 days. So when people started reading about that and started understanding, because he could go back to his family and then could infect his partner, which um, that was one of the things that they were like, oh no 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 no. I mean, communities were pushing the guys away. Mainly the guys were suffering the stigma the most because it's like nobody wants to be close to them because they think that okay, if it is in your sperm cell, maybe it could be your saliva, and, that kind of relation of ideas. But then with time, people started to understand more that it's not in the saliva. I mean, like they're more helpful to the community than harmful to the communities. So, I mean, the issue now started to go with, hey, let's educate the guys more that when you come from out of the ETU, you need to stay away from having sex for 90 days and more, at least for your own health, so that the partner that you love cannot get Ebola that will also infect the children or can have a reinfection of a lot of people. You don't want to reinfect people. So when people started doing that, but one way is it also is that community groups started doing anti-Ebola program, anti-stigma program. So the anti-stigma programs started getting into community, giving some of them support, like giving them rice and their food. Because once you give them food, and other people start getting closer to them, and the community sees that those people are not getting infected after 21 days. Obviously, they start welcoming these guys back into the community. But from the start, sure, it was an issue of people taking the threat of contracting Ebola.
Other audience questions?
Yeah, it's a process. So I mean, I don't think Senegal would not have been able, the government, to run an ETU probably. Um, they would have relied on external support. And I think the reality is that if there's another case, another outbreak in 2 or 3 years, we're probably still going to have to see international actors come in and take on some of the higher level interventions. But what we're moving towards now is making health facilities safer so that we don't see outbreaks. I mean, the idea really is to get to a point where you don't see an outbreak go to this scale, right? There will be another Ebola case in West Africa at some point. It exists in the animal population, and it will come up again. The idea is to keep it small and to keep it there. So, I mean, that comes down to a lot of training, support to health facilities. You want health workers to be able to identify and report if they see a case. That doesn't happen a lot right now. The alert systems are weak. So, I mean, really, like I said before, Ebola looks like a lot of other things. So we should be seeing a lot of alerts from all over West Africa. We're not seeing that. That means people don't know what to look for, or there's not a system in place for them to sound the alarm when they see something. And if they do sound the alarm, is it going to be investigated? So will the central ministry dispatch a team? So there's interventions that need to be done at a whole range of levels, from community health workers and nurses at the health posts to know what to look for, and then having a system to escalate it, and at the same time, IPC, infection prevention and control in the health facilities. You know, Ebola affects health workers more than anybody else, really, because they're the ones who come into contact with body fluids. So if you can improve IPC standards and keep health workers safe, it'll go a long way to preventing the spread like we've seen in this outbreak.
I think more to that. If you look at community approach, I think communities should be more conscious to like report cases faster, and people should just be also educated. Like it's going on in Liberia, a little bit in Sierra Leone. I mean, Guinea is a deep cultural mix with religious issue, so it is difficult to kind of penetrate into Guinea to get the idea grounded. But we hope that with time, we don't want to say, okay, what happened in Liberia should happen. Like you see body on the street, definitely when that happens, you stand up immediately. But I mean, people should be taught to like keep chlorinated water in their homes. When you come from out, washing hands, simple things like washing hands was a major thing in the fight against Ebola. Should be something that is now part of the society. If we make that like in Liberia, you wouldn't come from out. Like if I came from out, I don't want to touch anybody. Go straight into my bathroom, take off everything, put it in the tub, and I will sit there and wash it. I mean, it's hurting, but if you get that kind of practice, even though I don't touch anybody though, but I just still I'm afraid that I don't want to like bring something home. You know, if people can just wash their hands, report cases if you see something strange. I mean, the hotlines should always be open and active, not to say, okay, there's a hotline, people call and the response is slow. Like I was in Dakar before coming here. That's one thing the government has done there that is most effective as well. If that can be adapted in other countries, the hotlines are practically everywhere on the street. So if you get there, you'll be the first message that you receive on your text phone comes with that hotline. So if that can be done in other countries as well, then it becomes like a local solution. But I don't see any health crisis or happening in any part of the world that remains with that country alone. I think it becomes a shared responsibility for others as well. So yes, if you want to say it's a local solution, the local solution should be preventive rather than being curative. Once we get to that curative level, we cannot continue alone. Definitely help will come from outside.
Thank you. So we're just about to the end of time, so I'm going to give you a few seconds to say some closing thoughts. And if I could guide you in your closing thoughts to address, you know, here at Global Giving, we are in a lucky position where we can influence some funding. So as we look to the future, what are things that we as Global Giving should be looking at investing in? You know, as hopefully cases wind down and more long-term recovery or strengthening becomes more.
Okay. All right. First, I want to say thank you to Global Giving for having us, and we really appreciate that as individuals and our organization level as well. But I think just to close, and thank you also for coming. And just to close, I think one thing that Ebola has done to the world, it has made the world to look at health issues much more critically and look at not just providing help, but providing a more sustainable help to people. So if the communities will see a project, I think it most of the funding shouldn't go much to higher only higher organizations anymore. It should be targeting the CBOs as well to do preventive programs and also health educational program, not just health, but maybe the next crisis could come from educational crisis. I think transporting more ideas to other communities, let's try to do the reverse. Let these communities start sending more ideas of their own to us, and then we can package that well. So let's start looking, maybe you can start looking at little projects that make meaning in prevention and support education more, because the more enlightened a particular generation becomes, the more troubles that will drop, and the more consciousness that arises. Thank you for having me.
So thanks. Yeah, I mean, International Medical Corps is thinking about this in terms of 4 key pillars for right now. One is getting to zero. We're not done yet. So I mean, we all want to think about preparedness and about strengthening the health system, but we're not done yet, and we really can't kind of take our foot off the gas, especially in Guinea. We need to stay focused there. Number 2 is health system strengthening and rebuilding the health system to function safely, like I said, and to be more effective. You know, Liberia only has 51 doctors. Before the Ebola outbreak, only had 51 doctors in the health system. That's for 4 million people, right? And so that doesn't work. We need to invest in training. We need to invest in health worker education, in making sure that health facilities have water. I mean, there's some very basic things that we need to do. Engaging communities more. So working with CBOs, working with communities on case identification for Ebola, but for other infectious diseases. These countries that are most affected by Ebola also are affected by Lassa, are affected by cholera, are affected by malaria. There's lots of preventable deaths out there. And we need to work with communities to do those easy interventions. They're actually really not complicated to prevent and respond to these health problems. And then finally, preparedness. So there will, like I said, there will be another outbreak. Maybe it won't be Ebola, maybe it'll be something else. But we need to be prepared in terms of supply chain, in terms of the ability to deploy rapid response teams, which none of these countries had, to deal with outbreaks where they happen and keep them there. If there's going to be an outbreak, you want to keep it small. So it's about training on disaster response, on health crises, and having dedicated people and supplies and protocols to be able to react. So those are kind of our 4 areas of focus for right now and for the months and probably years ahead. It's going to be a long process to get from 51 doctors and hospitals with no water to a health system that can deal with an outbreak like this or of another disease on its own. So yeah, and just to echo the thanks as well for hosting this and for everybody participating.
We want to thank you. I know I personally, and I know speaking on behalf of everyone else, feel really, really lucky to have your expertise and your minds and your opinions here to let us know what your experiences and thoughts are. I know that there's lots of questions in people's brains that they didn't ask. So hopefully you guys can stay a few minutes longer and chat with some people. But thank you again for coming, and thank you also to Jackie and Sarah who put a lot of work, and Juan who put a lot of work in organizing.
Or guinea pig.
Yeah. And
I feel good. Like physically, I feel like kind of warm, but then I also feel kind of like strange.
Yeah, and the heat and humidity.
But yeah, but like having to go through.
Yeah.
Great. Well, thank you, everyone.
Thanks.
I just want to give Blair a second if you want to plug the impact evaluation back talk. Great. All right.
Hello everyone, I'm Blair. I work at the York on the 31st of this month. In conjunction with our feedback labs, we are organising a lunchtime session at 12:30 on measuring impact around accountability, how we think about what we have, who's doing it really well, and how we can improve. So please come along, you're very welcome. Those are in a yeah. So I recommend it. They're on Facebook.
Great. Thank you.
Yeah.
Blankets, like, run a race.
Do you want to put